Let me explain a vicious cycle that's increasingly common: recurrent urinary tract infections in children, leading to repeated antibiotic courses that disrupt the gut microbiome, paradoxically increasing kidney stone risk even while treating the infections. This connection between antibiotics and kidney stones surprises many parents and even some healthcare providers. The mechanism centers on gut bacteria. Antibiotics, especially broad-spectrum antibiotics, kill not just pathogenic bacteria causing infections, but also beneficial bacteria including Oxalobacter formigenes. This particular gut bacterium degrades dietary oxalate, preventing its absorption. When Oxalobacter is eliminated by antibiotics, oxalate absorption from foods increases dramatically. This elevated oxalate appears in the urine, hyperoxaluria, and drives calcium oxalate stone formation. Let me describe the vicious cycle I'm seeing clinically. A child has anatomical abnormalities, perhaps vesicoureteral reflux where urine flows backward from bladder to kidneys, or voiding dysfunction where incomplete bladder emptying creates infection risk. These underlying issues cause recurrent urinary tract infections. Each infection gets treated with antibiotics. The cumulative antibiotic exposure over months or years progressively disrupts the gut microbiome. Gut dysbiosis increases oxalate absorption. Elevated urinary oxalate increases stone risk. Now the child has both urinary tract problems and kidney stones, each complicating management of the other. Prevention strategies must address root causes. Identifying and correcting underlying causes of recurrent UTI is essential. This might mean surgical repair of reflux, behavioral interventions for dysfunctional elimination, or addressing constipation that contributes to urinary retention. Prophylactic approaches using low-dose antibiotics or other strategies can reduce infection frequency, though this must be balanced against microbiome concerns. When antibiotics are necessary, choosing microbiome-sparing options when possible, narrow spectrum rather than broad spectrum, minimizes collateral damage. Post-antibiotic recovery protocols deserve attention. Probiotic supplementation after antibiotic courses is commonly recommended, though I must note that evidence for successfully restoring Oxalobacter formigenes specifically is mixed. Most commercial probiotics don't contain this species. Dietary modifications during the vulnerable post-antibiotic period, being more cautious about high oxalate foods temporarily, provides a margin of safety. Monitoring urinary oxalate in high-risk children identifies those developing problematic hyperoxaluria from antibiotic-related dysbiosis. The diagnostic challenge complicates matters. Urinary tract infection symptoms and kidney stone symptoms overlap significantly. Both can cause painful urination, urgency, frequency, and abdominal or flank pain. Sometimes children present with both conditions simultaneously. Comprehensive workup when a child has both UTIs and stones is essential. Imaging to visualize stones, voiding studies to assess bladder function, metabolic workup to identify stone risk factors, and urine cultures to distinguish infection from stone-related symptoms. Antibiotic stewardship becomes critically important in this context. We must balance the necessity of treating bacterial infections. Untreated UTIs can cause kidney scarring and sepsis, with minimizing microbiome damage from antibiotics. Alternative prevention strategies deserve more attention and research. Behavioral interventions teaching proper toileting habits and complete bladder emptying can prevent many UTIs without medication. Low-dose prophylaxis using agents with less microbiome disruption shows promise. We need better approaches because the current cycle of recurrent infections requiring repeated antibiotics creating stone risk is failing too many children.